But you know, someone who's 39 and having a baby may not have had an HPV vaccine. You know, even in their early 20s.
I think the cutoff is 25, where they recommend.
Right, because after that,
12
what's the
and
point?
25.
Kind of what's the point? So HPV might be another one that we would ask about. So HPV, herpes, TB, I'm trying to think if anybody mentioned anything else. GBS, anything else? All right, hold on a second. I'm looking for my list. Okay. Just put this up here really quick. There we go. All right. And just kind of an FYI, when we're looking at pregnant women and STIs, there's sort of the distribution that we might see. This is from CDC, so just put it off their website. So chlamydia is another one. Trichomoniasis, so trick is another one that can be transmitted sexually. Hepatitis B, HIV, syphilis, HPV, all of those things we're going to try to screen for because they can all impact on potentially fertility and or delivery and or the fetus. Another set of things that we're concerned about is what we call the torch infections. Has anybody heard of those? Okay. Torch infections, oftentimes what you'll see drawn on a patient is what we call a torch titer. Okay? T stands for toxoplasmosis. All right? It's not sexually transmitted, but it is something that can cross the placenta. All right? It's a bacteria. O stands for other, believe it or not. So other includes all these things that we mentioned that we haven't had on the list. Things like GBS, things like rubella, things like, rubella is the R. Things like GBS, things like Hep B. Let's see. I think if there's anything else I want to think of. R is rubella. That's another one that they test for. C is cytomegalovirus. Okay, that's another virus that can cross the placenta. And then the H is your H's. HPV, herpes, HIV, etc. So they'll do a titer to see whether or not there's been any acute exposure, any acute infection, what the level of antibodies are. Because these infections in particular can cross the placenta in the first trimester, and as a group can cause things like mental retardation, congenital anomalies, deafness, malformation of organs, fetal demise, spontaneous abortion, etc.
Can you repeat T?
I'm sorry?
Can you repeat T?
Toxoplasmosis. There we go. So there's a lot of things that we have to be concerned about. I'll put it back down. Toxoplasmosis.
Is that the one that's related to cat litter?
Yes. So that's why they tell women to stay away from cat litter.
Is that the only way it's transmitted?
Hmm?
Is that the only way it's transmitted?
No, it can be transmitted with raw meat. They might tell her not to eat sushi that has something that's raw in it or uncooked, not to handle raw meat, and then not wash her hands afterwards. I'm trying to think what else might be a possibility. So it is something that lives in uncooked food and or feces. So it's kind of a GI type of exposure. So here we've got what pregnant women have, okay? And bacterial vaginosis is the most frequent, all right? And that's just basically a generic bacterial infection of the vagina. It does cause discharge, burning, oozing sometimes. Then we've got herpes, all right? And that's pretty common, surprisingly. Chlamydia, surprisingly, even though it's really, really high in adolescents, you don't see it as frequently in pregnant women. And these are 2010 statistics. Trichomonas on down, gonorrhea, much less frequent than chlamydia, which is also surprising. They tend to go together. Hep B, HIV, and then syphilis. So in pregnant women, syphilis is not the population where that's increasing. That's increasing in, unfortunately right now it seems to be increasing in gay men. So that's the population where you're seeing an increase in syphilis occurring. And then there's also, and I didn't get a whole lot of information about this, there's also a super gonorrhea that's out there now, which I guess is a resistant strain to everything that they've tried to treat it with prior to this point. So STIs, I'm just trying to paint a picture that STIs are a big, humongous, significant problem for our reproductive population and for adolescents in particular as well. So let's look at the slides I've got and kind of talk through them really quickly for 5 minutes so I can at least tell you what I want you to pay attention to, okay? All right, there we go. Well, and, good, okay. All right. So we know that STIs can be transmitted sexually, reproductive tract, so that's vaginal, anal, or oral, okay? So anyway. We talked about the fact that women are at greater risk because they don't identify when they have symptoms. They're also at greater risk because of the fact that their reproductive organs are structured differently than a male's. A woman's reproductive system is enclosed, basically, and by nature, it's a lot more moist where bacteria and viruses may grow and proliferate, all right? And then there is monthly bleeding that occurs, which also, if you have sort of a menstrual period in conjunction with an STI, the bacteria has blood to feed on, which unfortunately just makes them grow even more. So there's a lot of situations that are unique to a female that make it much easier to contract an STI and then to keep it for a prolonged period of time. Some of the risks that they contribute to, we know HPV contributes to cervical cancer. We know infertility might be an issue because of what we would call pelvic inflammatory disease, and we're going to look at that in a minute. And then we know that infections can be transmitted to the child. The CDC has a classification system. If you want to take a look at that, that is in your book. And it's basically how they classify types of STIs. STIs that cause cervicitis, STIs that cause vaginal discharge, STIs that cause open sores like a chancre, STIs that cause warts. I mean, there's all different kinds of classifications. Bacterial vaginosis is, again, as we see, the most common with pregnant women, but what it puts them at risk for is things like preterm labor, preterm rupture of membranes, infection of the amnion and the chorion, and PID. So depending on what the organism that's causing it, they're either going to treat it with an antifungal or they're going to treat it with an antibiotic. Chlamydia, that's, as I said, one of the popular STIs, most common in adolescents. It causes, along with gonorrhea, that ophthalmia neonatorum, that disease of the eyes that can cause retinal damage and blindness in a newborn if it's not treated. So what do we do for a newborn? Every newborn that comes to us, what do? We give erythromycin ointment. We don't care if the mom has never been exposed to anything in her life. We're going to treat the baby anyway. So that's one of the things that we just blanket prophylactically treat the entire world, because it's better to do that than to miss one case and cause preventable blindness in a newborn. Okay. Gonorrhea is chlamydia's best friend. All right, they go together. They tend to co-occur, and so typically if you see an individual with a positive gonorrhea test, you're also going to test them for chlamydia, because you can see how much more frequent chlamydia is than gonorrhea on that slide, on that handout I showed you. Again, the big concern that we have for gonorrhea, like chlamydia, is treating the newborn and preventing eye infection. And then here's some doses that you may see being gonorrhea being treated with. And the thing, as I said, the thing about gonorrhea right now is that they've identified a super infection, and I'm not really sure what they're treating the super infection with at this point in time. But it's something that has developed some resistance to everything else. Herpes. Herpes is an issue for a number of reasons. Women who have herpes and are positive for herpes may take their medication throughout their pregnancy. And what's a typical medication for herpes? Anybody know? I'm sorry? Valtrex, okay. That's one of the most common ones, and you will probably see women who are positive for herpes that are pregnant taking that. So presumably, if they're on the med, they may not have an active outbreak, okay? But women who do have active symptoms, who are developing herpes vesicles vaginally, cervically, on the labia, etc., are considered to have an active infection. How are we going to deliver those patients? You know? We're going to deliver them by C-section, because what's the risk? That the baby may get the infection as they come down through the vagina. So that's one of those situations where either herpes travels up, or it's already up there with active lesions on the cervix or on the vaginal wall, or the baby travels down towards the active lesions and is exposed at the time of delivery. And herpes can cause very, very significant sepsis in newborns. So we would like to avoid it at all possible. So careful individuals are going to tell a mom if they have active lesions, they're going to be sectioned, and they're going to be sectioned before their membranes rupture. Because once membranes rupture, you have a fairly brief window of opportunity before what is the point, and that's about 4 hours. Okay. All right. We see that herpes, if the contamination occurs during birth, it can cause brain damage, mental retardation. If it occurs prior to birth, it can cause premature delivery. If it's an exposure that happens, like, let's say, in the first trimester, there may be enough compromise that we have a low birth weight baby, an interuterine growth restricted baby, or possibly a fetal demise or a spontaneous abortion. So one of the things that we have to be very aware of. Syphilis, as I said, is now they're looking at a rise in gay men. But syphilis is a bacterial disease that can cross the placenta. And at any point in time that there's an active infection with syphilis, during a pregnancy, there can potentially be fetal morbidity or fetal mortality. So, again, a patient who is exposed, we would want to know that as soon as possible. And the typical treatment for syphilis is still a version of penicillin. Now, pelvic inflammatory disease, I just wanted to make sure that we understand this process, because this is one of the big issues that goes along with STIs, and it's one of the big causes of infertility. Yeah. Okay. Oh, my. Oh, I'm going to touch my fingers. I think I better just erase. Okay. Do not want to do that. All right. Does anybody know what PID is? Describe it. PID stands for pelvic inflammatory disease. So, all right. Okay. So we talked about already the fact that a woman may not be aware that she's been exposed to, let's say, gonorrhea. Okay. Gonorrhea tends to, if there's going to be any symptoms, it's going to tend to be maybe a discharge, some burning on urination, some itching or some inflammation, but maybe not, okay? So let's say she's been exposed to gonorrhea, and she's not aware that she's been exposed, all right? Partner does not let her know, all right? She doesn't receive treatment. The infection continues, all right? Eventually, the infection that started down here in the vagina, she's not pregnant, mind you, eventually it's going to spread to the point where it goes up into the cervix, and it causes cervicitis, okay? And then once it goes past the cervix and through the cervical os, it's going to go up into the uterus. And at this point, it goes from being a lower reproductive tract infection, which would be vaginally, like cervix down, to being what we call an ascending infection, because it's ascended, okay, up into the reproductive organs, all right? Okay. So this gonorrhea bacteria, they're prolific. They reproduce rapidly, you know. There's, let's say, this woman has had her menstrual periods. There may be some, or maybe she is going to start it in the next few days. So there is basically blood that the bacteria can feed on, all right? So that makes them proliferate even more. They grow in the uterus. They begin to grow out into the fallopian tubes, okay? And at some point, thank heavens, she starts to feel sick, okay? But it might be a while, seriously. You know, maybe she just feels kind of crampy, but she's not paying a whole lot of attention to it. Maybe she thinks she picked up the flu from, her brother or a sibling or someone that she works with, or, some kind of intestinal bug. She doesn't feel good. But eventually, when the infection is getting to this point, she's going to develop a fever. Finally, she's going to have some symptoms. She's going to have a lot of pain. She may have burning on urination. She may have a purulent discharge vaginally. It may be malodorous. But she's finally going to start to realize that there's a problem, fortunately. And hopefully that's going to take her into a healthcare provider. But unfortunately, by the time she gets to the healthcare provider, she's developed what we call PID, or pelvic inflammatory disease. Because now her entire pelvis is inflamed. It's infected. Okay? Sometimes in very, very extreme cases, women will develop abscesses. They'll develop a uterine abscess. They'll develop an abscess between the fallopian tube and the uterus. They have pockets of pus that develop that need to be treated or drained if possible. And this entire pelvic area is just inflamed, hot, purulent, discharge, painful. There's adnexal tenderness when the cervix is touched. I mean, it is in its worst forms. It is just, it's like the sickest you would ever feel, basically, okay? So potentially, she's either going to have to go on antibiotic therapy at home, getting home care with an IV. They may admit her if she's so sick that she's dehydrated and she's febrile to the point where she needs fluids and etc. If she's lucky, it's not spread this far, and they're just going to give her mega doses of antibiotics. But what do you think the long-term outcome of this situation is? Well, certainly a compromised fertility, absolutely, because now she has scarring and damage to these fallopian tubes, okay? And what does that put her at risk for? Puts her at risk for ectopic pregnancy, in addition to putting her at risk for having a difficult time conceiving, okay? So certainly PID, in its worst cases, can really, really wreak havoc with someone's future reproductive plans. That's why it's so important that we identify patients who might be at risk for STIs or who have STIs before it gets to this point. So that's why, it may seem crazy, but that's why they should be screening every pregnant woman and every adolescent that walks through the door that's sexually active. So there are a set of recommendations that the CDC does provide. Chlamydia screening for any woman under the age of 25 that's sexually active. Gonorrhea screening for at-risk sexually active individuals. Syphilis, HIV, chlamydia, and hepatitis B screening for at-risk pregnant women on their first prenatal visit. And then for gay and bisexual men, syphilis, chlamydia, gonorrhea, and HIV. And those are just the biggies, because those are the most frequent. All right. So there's no way to prevent this unless you do education and screening. The rest of the slides talk about PID, treatment, and what the consequences might be. And then the last one is just about HIV. The one thing I do want to have to point out to you just really quickly, let's see, darn it, previous, is that statistic of 25% of newborns born to infected moms are likely to be infected. And that's a statistic that we've been able to shrink with treatment and management. Okay, so it's an important thing that we've made that kind of progress with HIV. In terms of what's going to be on the quiz, there's probably like 4 or 5 questions. They're mostly related to treatment and to looking at impact on mom-baby infertility. Okay? So if you look through the slides and you do the reading and you're aware of that, you should be okay. All right, any questions? And the other thing, too, is the take-home is make sure you always look at your patient's prenatal records, because how they've been exposed dictates how you manage the problems that come down the pipe. All righty, thank you guys. I really appreciate it. And don't forget, we are in our offices. I'm going to mine now. I just need to heat up my lunch. I'm in 361. Professor Walker's in 360, and Professor Van Meter's on the other hall, but I don't know what her number is.
We're all on the third floor?
Yeah, we're all on the third floor.
Where's the pinning thing? Is it in the third floor lounge?
I do not know. Does anybody know where the pinning thing is? Is it at 1 o'clock? 301 at 1 o'clock? So is everybody going to the pinning thing first? Is that the deal? Okay, all right. All right, we'll do the best we can. Yes, ma'am.
Just pin us and let's go. Nothing cheesy.
Let me email you because that's in my notebook. Even if I saw that, I had to do it.
I'll give it. I'll do it. I'll give it some.
I will.
I'll give a speech. I'll give a great speech. Quiz.
Say it's mastitis. Okay. I'll just okay. All right, I'll see you tomorrow.
I just done the quiz. See, I thought I got an 18, but I got a 17. I've heard a lot of people say that.
Really?
Yeah, so I'm gonna ask
Because
them
I
about
was
it.
looking at the things, and I got everything right. I was like, sure.
Which one did you get wrong?
Number 4, I don't know what that was. That form B.
You had B, I had B too.
Yeah, same with that girl. She said that she got it wrong too. Yeah, it's not so.
That's what I got wrong too.
Oh,
What'd you put?
I put B. Yeah.
But it was right. It was right on the...
Yeah, it was right on the thing, right?
Okay, I'll ask him about that.
Yeah, it's on the thing. And the other girl back there, she had the same thing as I.